Okay, hello. Welcome to this afternoon's webinar focused on infections in the immunocompromised. My name is Leon Worth and I'm stepping in for Monica Slavin today. I'm one of the other stream leads for the National Centre for Infections in Cancer, an NHMRC funded Centre for Research Excellence. This CRE is focused on surveillance, implementation and novel approaches to detection, diagnosis and management of infections in patients with cancer, and is a health services research hub, if you like, integrating national investigators, PhD and postdoc researchers. Before we start today, we do acknowledge the traditional owners of the lands on which we are found and pay our respect to elders past, present and emerging. So, as part of World Antimicrobial Awareness Week, it is wonderful to highlight and acknowledge together the importance of antimicrobials in managing high-risk and immunocompromised patient populations. That's what this session is all about. Increased infection risk in these patient groups brings the need for evidence-based practice regarding prophylaxis and treatment. I think that goes without saying. And this also then heralds the need for stewardship programs which are not only focused upon antibacterial agents, but also encompassing antifungal prescribing as a key element. So we have 4 presenters today in a terrific program which encompasses antibiotic allergy delabeling, CMV infection in stem cell transplant settings, antifungal stewardship, and the role of the nurse practitioner in antimicrobial stewardship. From a housekeeping point of view, I'd just ask if we could reserve questions for the end of each presentation, and our speakers will run for about 25 minutes each. So without further ado, I do warmly welcome here today and introduce our first presenter, Associate Professor Jason Trubiano, who holds appointment at Austin Health, Peter Mac. Many will know Jason, I think, through a number of forums. But he is also an investigator with the National Centre for Infections in Cancer, holds numerous grants and has upscaled services concerning antibiotic labeling here in Australia. So I'll hand over to you now with thanks, Jason.
Thank you, Leon. That's a very kind introduction. It's nice to be with everybody, albeit virtually. And so today we're going to be talking about our baby of antibiotic allergy. I think we're probably in a unique position as NCIC because most of our studies have been done at Peter MacCallum. So we have a large proportion of patients that are immunocompromised by default, which is great. So I'm just going to see if this moves forward. Okay, so it really starts, I'm going to start with a case example, and this is a traditional journey of misadventure. And Mrs. X presents with a penicillin allergy, as do 1 in 10 people to an Australian hospital. That patient then often will need antibiotics that are beta-lactam based for an infection where our therapeutic guidelines are recommended, but they continue to avoid it. They get crap second-line antibiotics, vancomycin, clindamycin, fluoroquinolones, all of which lead to this accumulation of other adverse events and side effects. They lead to poor health outcomes, inappropriate antibiotics, infections, mortality, and then poor hospital outcomes in the terms of the bean counter, increased hospital costs, length of stay. And this has been shown nationally and internationally. So the issue is, well, how does this differ for an immunocompromised host? What are the host factors that are important? And also more than that, what about the phenotypic factors? What we mean by that is the type. Is it a low risk, medium risk, high risk allergy? And so we're going to focus on 2 of those concepts today. I've also put a little icon up in the top right. So I'm going to try and highlight where the studies have included immunocompromised hosts and a little recognition of our leader there, of Monica. I won't put her photo though on each of the slides. So these are some of the poorer outcomes associated with hospitalized patients with an antibiotic allergy. We've mentioned some of them. There's lots more emerging: delays to appropriate antibiotic therapy, EMR record errors, surgical site infections, C. diff and MRSA. These are just a growing list of associations. And as mentioned, 1 in 5 patients will have an antibiotic allergy, almost 18% of all hospitalized patients. And it's a bit of a journey. That data came from our first study that we did in collaboration with NCAS using NAPS data. And so if we look at beta-lactam allergies, clearly the big one that we focus on, 1 in 6 patients will report a beta-lactam allergy. And this is data captured from our whole of hospital surveillance program, which we'll touch on at the end at Peter Mac at Austin, where we actually assessed everybody that presented to hospital with an antibiotic allergy. And so if we look at prevalence globally in those that are immunocompromised, it's higher. And it's pretty disturbing when you go across to North America and you find that almost 35% of hospitalized hematology patients have a beta-lactam allergy label. We found somewhere in the vicinity of 24 to 25% at Peter Mac back in 2014. And other studies are coming up with, prevalence figures in that range. So it's a huge burden and it's a global burden. And when we look at the global impacts, I'm going to go back to that study I mentioned. If we look at us in Australia, when we performed that study of over 21,000 patients that looked at prescribing in those that reported an antibiotic allergy versus those that didn't, you can see the odds ratio of receiving a quinolone, glycopeptide or carbapenem was significantly higher in those patients with an antibiotic allergy. In that data, we also had a decent proportion that were immunocompromised. The North Americans then go and do the study, congratulations, in 5 years later, and showed in half the patients the exact same thing. And it's quite interesting, you see the ratio, the odds ratios are very similar, quinolones, glycopeptides and carbapenems, almost identical for carbapenems in their hospitalized patient data from a multi-center study. So it's nice that this data can now be replicated internationally. And if we pulled out those immunocompromised hosts, well, the effects are magnified. Inappropriate use was up, also quinolones and glycopeptides, all of those with confidence intervals that do not cross 0. So here are the 3 ways I think if we're going to scale or we're going to look at antibiotic allergy in the immunocompromised host, we've got to have ways of assessing and approaching these patients that are specific. We've got to think about emerging immunocompromised host factors and then employ whole of hospital programs. So let's start with assessment and approach. And so I've shown this at many of my talks. Apologies. We're very proud of this antibiotic allergy assessment tool that was really pioneered by Misha Devchan, who's one of our AMS pharmacists at the Austin. And this tool has now been employed in all of our programs at point of care and it has now been validated internationally and also locally. It's a nice system because it's traffic lights, green, orange and red, for go for green for challenge, red for don't touch them. And the overall sensitivity of this tool was excellent, 91%. But it was actually higher in nursing oncology groups. So this gave us a really idea of embedding this in oncology and hematology care, and I'm sure Belinda will touch on that in her talk. There are lots of other tools that might grab your attention, and these are increasingly published. This one was published in the supplement of a lovely article in JAMA by Shenoy et al. And then this one and the last one was taken from a randomized control trial, and I've put the reference there, that also took a risk stratification approach. Very much similar in all respects, though, when we look at the low-risk criteria. But the pinnacle is a clinical prediction rule. We're all looking for clinical prediction rules. How can we, with a couple of variables, predict who's low risk, who could have a challenge at point of care? And it almost feels mythical most of the time searching for this. Groups in the UK have had a go at this. This study was quite nice, but it was only limited to those with IG-mediated or immediate allergies, which really doesn't apply to a lot. And then an Australian study used retrospective data. Again, quite a good study, but this very hard term of grade 1 rash is very hard for a non-allergist to use. So we had a go at this and we used our prospective data set where we looked at everybody with an antibiotic allergy from 2015 in our data, almost 700 patients, and we came up with PenFast. And so this is a simple algorithm that can be used. How long from the reaction? Was it anaphylaxis, angioedema or scar? Did they need treatment? And then you get a risk stratification based upon that points. A score of 0, very low risk. 1 in 100 patients would actually have a true allergy in that setting. And I think the strength of this was that with the external validation in an international setting and also locally was almost 2,000 patients, a PenFast score of greater than 3 had a very high negative predicted value. And as mentioned, it was externally validated. And again, the strength was that we included immunocompromised hosts. Almost 50% of the cohort were immunocompromised, which means we can apply to this setting. And this is a now readily available tool via QXMD app or online. So everybody has full access to this tool. So you've done all this, you've got your assessment tool, you might use a clinical prediction. Well, can I challenge my patient now? And if you do a PubMed search looking for a criteria, it's got problems. So you'll have vague criteria and everybody uses their own criteria. Many of them are almost desensitizations, the number of challenges they give people. They're led by allergists in the outpatient setting, not much good to any of us. And again, we're immunocompromised included. So we're going to have a look at that data. So I've picked out studies that have chosen a low risk criteria in inpatient settings. So what can we do in the inpatient setting? And you can see there's a description of criteria. Most of them are based upon benign rashes more than a year ago, but generally more than 5 to 10 years ago. And definitely childhood reactions were predominant throughout. If you look at the positive rate, it's very small. So 3.4% overall would have had a positive oral challenge. So you are going to delabel the vast majority. But if we're looking at criteria that are easy to use for a non-allergist, it needs to be a single dose challenge. It can't be 5 steps. It's got to be data with the inpatient setting, and it's got to be non-allergist led. And I think I've highlighted Tanya's paper here from New Zealand. This was published in JAC. I would implore you to read it. It's a lovely paper, and it was a practical approach to challenging using an AMS pharmacist-led strategy. So what about data in the immunocompromised? This is including not just low risk, high risk. Generally, they involve skin prick testing, intradermal testing, and patch testing. That's the acronyms there, SPT, IDT, and PT. There's a range of phenotypes. I think the Americans cheat, and I'm sorry if there's any Americans viewing the talk, but a lot of times they exclude people with anaphylaxis or elderly, which I think are important if we're looking at those, and penicillin only is generally the approach. Again, if you look at the positive rate, it's very small. I'll point out one of our studies actually, where the positive rate was 38%. And this was in a group of patients that had severe delayed reactions that were well phenotyped. So if you actually pick patients that you think have an allergy, you can get quite a high hit rate. And again, 50% of those patients were immunocompromised. This is the other important thing. Well, is it safe? Can I do it in my hospital? A lot of zeros. Big donuts, 0% is serious adverse reactions requiring therapy in these studies. So I certainly think we can employ them at point of care. So now we've got weapons. Choose your weapon. Well, I think direct oral challenge is where we should mostly be aiming because we don't need specialist service for these. They've got to be single dose, 250 milligrams of a single dose tablet, 1 to 2 hour observation. Pick your criteria, childhood rash, unknown reaction. If somebody doesn't believe that nausea and vomiting is a type A side effect and they can't be directly delabeled, well then challenge them as well. Skin prick testing and intradermal testing, well this is more for those moderate risk types, urticaria, angioedema. There's standard panels now that are widely used. We have the major and minor determinants of penicillin produced by Dieta, which we can get. A step towards scalability with having this TGA approved, but otherwise you can get it. And when you dilute it out and use it for a lot of patients, it's actually quite cost effective. And then patch testing and novel in vitro or ex vivo diagnostics. Well, this is for specialist setting. These are not for scalable processes, things like Stevens-Johnson syndrome, DRESS, and there's some of the photos of our patients there. So what about some particular immunocompromised host factors? So there's challenges in this group. We'd be blind to say that they weren't challenges that we have to understand. And the big one is burden. You know, if you're in the US, you've got 35% of your cohort that have an antibiotic allergy. You feasibly can't address all these. And so I think this was a nice paper actually that looked at solid organ transplant and hematology patients and found that prevalence figure upwards of 30%. And I think this is the group to target because in the first 100 days post-transplant, 94% will receive an antibiotic. So we should focus on pre-immunosuppression, pre-transplant, and get this group as a target. The other thing is immunology. We're learning about this. So hairy cell leukemia is an interesting disorder that we see a bit at Peter Mac. And we looked at this group because we noticed a high prevalence of allergy. In fact, when we looked at it, 60% of hairy cell leukemia had an antibiotic or drug allergy and must be the result of some immune dysregulation. So we need to explore and understand these evolving immune and drug interactions as well. Predisposition. No longer can we just not try and prevent these reactions. There's an increasing number of HLA associations. Allopurinol has one. Vancomycin we found has one. And Dapsone have them. And the right ethnicity, we should be ordering these. So greater focus on pharmacogenomic prediction is required. And steroids. This is a bane of our testing. There's 40 milligrams they get with myeloma therapy a week. but steroids do not have to be a contraindication to testing. And if you look at actually quite old data, both long-term and short-term therapy that's under 30 milligrams of predequivalent a week is not a barrier to testing and doesn't produce false negatives. So even those have a solution. And the benefits are numerous. And I've just highlighted some here. There's a paper you could find on each of these, but these are practical things where we found antibiotic allergy to be appropriate. Febrile neutropenia, our guidelines are piptazo or alkefapine. So being able to use a beta-lactam is essential. Sepsis pathways, again, beta-lactam predominant based, getting people before they have sepsis to test them so you can give them the right antibiotic. And in fact, antibiotic allergies are associated with a delay to antibiotic therapy. Splenectomy is huge, amoxicillin therapy, and we get a number of referrals now from Spleen Australia. Surgical prophylaxis, particularly in the oncology space, using cefazolin, getting people in pre-surgery clinic and assessment clinics through to delabeling. And we haven't touched on it much, but gee, PJP prophylaxis, employing Bactrim or Respirum Fort is the key here, avoiding pentamidine and dapsone, which have their inherent issues. So here are some of the key benefits to delabeling in this cohort. So we've talked about assessment, we've got our approaches, and we understand our barriers. Well, how could we employ a whole of hospital program? And so Kim Blumenfeld really in the US has been a pioneer of this. And her programs have been really based upon utilizing electronic medical records, embedding the criteria, guidelines, challenge protocols within an EMR in Boston. And this has led to a large number of patients receiving penicillin test doses and cephalosporin test doses with a small number of adverse drug reactions. Now, the interesting bit here is that whilst they do a lot of test doses, I don't think they're practical. So do we really need to be doing a cephalosporin test dose in a patient that has a penicillin allergy? I don't think so, based upon cross-reactivity. So I think the test doses should be about delabeling, not about showing safety of prescribing. But this has been a huge step forward, and Kim's really been a leader in this. So we took a leaf out of that book and tried to employ an antibiotic allergy delabeling program with the support of Better Care Victoria early in 2019, which seems a long time ago now. And so this process was to really identify every single patient that presented to hospital, and we captured people Monday to Friday, more than 18 years, via active surveillance via an EMR report and also manual reconciliation. The manual one was done at Peter Mac and the EMR at the Austin. We also combined that with an AMS allergy ward round once a week, and then passive surveillance, referrals from clinicians, pharmacists. And then each of those patients were assessed by the tool that Misha Devjan created. Initially, this was done by our specialist nurses, but now has been transitioned to point of care, being done by all nurses and pharmacists on admission. Patients in this cohort, and we're only talking about the first 9 months in this data. We're looking at data that's about threefold higher than this now. We found 1,225 patients with a penicillin allergy. And when you split those into low and moderate to high risk, again, we get that split of about 50% that are low risk. And of that 50%, we were able to delabel 344 patients. And when you think about it, that's a huge number, considering people might be in and out for day surgery that you miss. They're critically ill in intensive care, and we haven't got data there. So to be able to delabel well more than 50% of patients was huge. And the vast majority was with an oral challenge. And the other one is direct delabeling. You can see the value of direct delabeling. This is the removal of a penicillin allergy just by taking a history and by medical reconciliation. I'm allergic to penicillin, but you look at the notes and the GP gave a Moxil 12 months ago, off with the penicillin allergy. The other one is even in the moderate and high risk, you can do direct delabeling, and we found patients in that same group. Oh, I've got anaphylaxis to penicillin, but again, I've tolerated a Moxil last week. So again, this can be an approach. And again, with our data, this is appropriate to the immunocompromised host because 41% of our published cohort was an immunocompromised patient, predominantly a hematology or oncology patient. And so in terms of infographics, this is the key result. So we were able to produce an EMR-enabled penicillin allergy toolkit. So we started with that manual paper form and we worked with Cerner, and now we have an inbuilt electronic form that's a mandatory to be completed at the Austin. And we're working with that process with Epic now to get a similar process in their system. 97% of people were negative on oral challenge. So in this study, 194 of 200 challenged were negative. We're well over 500 negative oral challenges now. We also did a follow-up study in those early patients at 12 months, and 95% were still avoiding, were no longer avoiding penicillin at follow-up. So these effects are long-lasting, and the consumer is certainly engaged. Significant effects on antibiotic prescribing, and you can see here 10-fold increase in penicillin use, a 2-fold reduction in restricted antibiotics, and a 2-fold increase in antibiotic prescribing. And this was used using a propensity score analysis with the non-delabeled control group. And I think everybody's got to look about cost savings now, and certainly we're able to save $335 per patient for every patient delabeled, and that data is soon to be published, which is a great outcome as well. But certainly there's some learnings, and I think if we're talking about scalability, you don't employ the same program for each hospital, and it certainly was a tale of two hospitals. So one's a cancer hospital, 90 inpatient beds, no allergy services. The other one's a tertiary referral service, 500 inpatient beds with all services available. One certainly still looks nicer than the other, and they're not the same. And whilst the patients, when you look at their pure numbers, may look the same, the median ages were the same, Charlson-Combs index was the same, penicillin allergy predominant, more sulfonamide allergies in the Peter-Mac group, we were able to get about 14% and 17% of all penicillin allergies delabeled. That's including moderate high risk. But the difference was we're talking about 1 to 2 challenges per week in the Peter-Mac group versus 5 to 6 in the Austin. So I think when you're talking about a smaller hospital, more integrated teams, opportunistic delabeling is the way to go. Training your immunocompromised physicians to refer patients, pick them up with nurse practitioners, and Belinda will talk to that. The other one's big hospitals, large groups to attract, well, you need surveillance delabeling. That's where your EMR comes in, automated reports, automatic flags. So there are certainly different ways you can approach implementation. So if we're going to talk about scalability, I think we need to address these things. So we need to address a healthcare gap. There's clearly a healthcare gap with antibiotic allergy. And we've shown it in previous papers and some recent ones again, that if you do antibiotic allergy testing in the immunocompromised host or transplant patient, you improve prescribing. So I think when you write that business case, we have extensive evidence now that improves prescribing. We need validated, effective tools. We definitely have that. We have risk assessment tools that have been internally and externally validated and been employed in whole of hospital programs. Cost saving, this was missing for a while. Lots of international data doesn't apply to us, but now we have economic data that show we save money when we employ antibiotic allergy programs. Engage stakeholders, we had this from the beginning. When we surveyed people back in 2015, they were engaged with employing these services in their healthcare network, and now we know consumers and patients are also engaged by the process. And policy, we need policy support. In 2018, the word allergy started to emerge in these guidelines. The therapeutic guidelines has had a paradigm shift in its approach. And hopefully in the new national standards, when we look at standard 3 that come out shortly, we see the word antibiotic allergy and antimicrobial allergy as a focus for antimicrobial stewardship programs, both in the immunocompetent and in the immunocompromised. So if we think about, I'm going to end with my ideal hospital. So we go back to that patient. Well, the patient with the penicillin allergy presents to hospital, they're immediately assessed on admission with whichever tool you employ in your system. And really it's embedded into an EMR. That's the way to go. You find a low risk and they're delabeled directly. They're delabeled by the team that are trained. They're delabeled by a pharmacist that leading the program. They're not always just delabeled by a specialist allergy service. If they're moderate to high, you've got linkages either with your own hospital or an alternative where you can perform outpatient delabeling via skin testing. But in that group, you might think about them harder. Could I risk stratify them further? Use a tool like PenFast, which actually allows you to challenge childhood urticaria and then move to delabeling via a more specialist service. And then over that, you've got this passive capture, ID, AMS, pharmacist, and the ICH clinician referring low-risk patients. And then at the end of that, you have a cohort with no penicillin allergy, and that's verified and backed up in your electronic medical record, and hopefully a My Health record in the future. And if you do, by some miracle, get some positive cases, you flick them back for outpatient testing to show even if they are allergic, they're able to tolerate other antibiotics. So in conclusion, I think we've hopefully shown you that penicillin and beta-lactam allergies are a significant burden on healthcare. The immunocompromised host has its unique challenges around employing antibiotic allergy programs, but we have solutions for that. And there's now a large body of evidence for inpatient interventions in particular with direct oral challenge and also skin testing. Whole of hospital programs are there to be taken advantage of and can be tailored to your hospital setting, big, small, or other. So I just want to thank everybody that's collaborating with us, a particular call out to NCIC and the Peter Mac and Austin crew. So thank you very much.
Thanks very much, Jason. Certainly very informative, and just enjoyed the way that you put forward to us here, not just problems, but also potential solutions here. I guess, and to say that if there were to be one element that you see as central to hospital-wide programs moving forward, what would you rest your hat on? I'm taken by EMR and some other comments you've already made today. But can you highlight what you would think is number one?
Well, I think learnings were that I hate the word stakeholder, but it's important. The stakeholder group, particularly nursing and pharmacy. So I think we underappreciated the importance of nursing when we rolled out these programs. And I think if you have nursing engagement in these programs, they're much more likely to succeed because most of that frontline assessment is driven. That first record of somebody's penicillin allergy is put in by a nurse in ED or triage. So I think we have to be focusing and engaging with that craft group. It's the key. The other things can flow. We've got all the protocols and EMRs, but you've got to get the stakeholders on board.
Sure. Thank you. And there is a question here from Kaz. Kaz?
Yeah, Jace, I'm really interested to hear your take on where we are at with policy drivers for this implementation, because clearly there would be quite substantial health economic benefits for this program, and we're yet to establish programs in aged care and primary care as well. Yeah,
that's huge, Kaz, I think. So I think that the thing we've fallen back and we haven't done enough health economics, and this is really the first local stuff that we've done. We're just starting to see that emerge. And you're right, you're not going to get implementation of policy done unless you're doing primary care. And there's still a big literature and literature gap in that group. So I think if we can progress with primary care, I think we're certainly going to get more movement in terms of policy as well, not just in a hospital setting. So yeah, big groups for the future, I think.
Michelle, did you want to raise your question in person?
Hi, Jason. Well done. Really great to see how well you've done in implementing these programs. Can you just point out whether you came across any barriers, particularly in the immune-compromised host with potentially a lot of stress and anxiety and competing with chemo and so forth? Yeah, no, great point. I was surprised actually. So we have had very few barriers in the immunocompromised host craft group because most of the clinicians are aware of the benefits of being able to give tazocin. So this was a good driver, and the other one was sulfonamide. So that's never been a barrier. Practically a barrier has been steroids and concurrent chemotherapy. And so outpatient setting programs are limited. Where inpatient, you can capture them at the end of their admission or before they start chemo. So I think in an ICH space, that inpatient setting removes some of those practical barriers. We actually found some of the surgeons in the Austin setting a barrier to implementation for their precious patients, particularly cardiothoracics. But apart from that, in fact, orthopedics super engaged because they want to give cefazolin. So I think if we use some of the things they want to drive, some favourite antibiotics that we also want to use, that's helpful.
Very interesting. Use the momentum wisely. Yeah. Well, thanks again, Jason. I think our time's up today. So we give you a virtual hand clap and many thanks for presenting here today.
Thanks everybody.
We'll move now to our second speaker for this session, who is Dr. Michelle Yong. Michelle leads much of the clinical trials work through the National Centre for Infections in Cancer, and she herself has a particular interest in viral infections in the immunocompromised. So I'll hand to you now, Michelle. You're going to speak to us today concerning improved outcomes of cytomegalovirus infection in recipients of stem cell transplant. So thanks, Michelle.
Thank you so much, Leon, and thank you for the invitation to speak. Hopefully you can all see my screen there. So I am speaking on improving outcomes of cytomegalovirus or CMV infection in a particularly high-risk immune-compromised host, and that's a haematopoietic stem cell transplant recipient. I just wanted, these are my disclosures. I've received honorarium speaker fees from MSD. So this is a different audience that I'm used to. So I just wanted to provide some relevant background to you all. So cytomegalovirus is a viral infection which is ubiquitous in the environment and is from the human herpes virus type 5 family. So the transmission is usually as a young adult and increases with age, and it's via infected fluids such as saliva, placenta, breastfeeding, through sexual contact, blood transfusion, and importantly, transplantation. Like with some of the other human herpes viruses, primary infection is by the majority asymptomatic, perhaps a febrile-like illness, and followed by resolution, and it develops lifelong latency so that we've never cured but has ability to reactivate. And we can find CMV in a very small but significant population of mononuclear cells. So CMV is very important in our region because seroprevalence is reasonably high. So population studies have shown that seroprevalence or exposure to CMV occurs in up to 90% of the blood of our population. And within the region, Asia Pacific, it's much higher compared to a European region. So around 90%. And the reason this is important is our Australian population and those coming in to transplant, and also our donor pool come from within this region. Allogeneic haematopoietic stem cell transplant is a curative approach for many people with blood cancers, such as myeloid leukemias. And although this is a life-saving procedure, infections are by far and away a major morbid problem of a transplant, so that 93% of all transplants have an infectious complication, including bacteremia, but quite significantly CMV infection. So it's the most frequent infectious complication in a high-risk group, occurring in 75% of high-risk patients. And not only does it cause direct problems into tissue, meaning that there's infection in the gut or lung, requiring extensive stay, but there's also treatment-associated toxicities associated with the antimicrobials that we use, an indirect effect of subsequent or opportunistic infections with other bacterial, fungal, or viral infections, and also resource utilisation, which I'll come to at the moment. So any impact that we have in improving outcomes with this serious infection will certainly have better outcome for this population overall. So one aspect of improving outcomes is sort of better understanding of what a viral load or CMV is in this population. So prior to this landmark study, it wasn't quite clear what was the clinical meaning of a viral load in this population. So CMV disease we understood well, but not so much a viral load. However, this study performed at the Fred Hutch in close to 1,000 allogeneic stem cell transplant recipients, was able to evaluate and associate a higher mortality of up to 20 times that of patients with a viral load as low as only 250 international units per mil. And this risk was certainly a much higher in the early period post-transplant within the first 60 days, but still held true for up to 1 year post-transplantation. So this was a really good improvement in our understanding that not only was disease causing quite a lot of morbidity and mortality, but also the presence of CMV viral load. Another advance in our understanding of CMV is that sometimes it's not solely just CMV in itself, but understanding that there's that with CMV comes other reactivation of other double-stranded DNA viruses. So this is a great study from Josh Hill at Fred Hutch, which showed that on the left-hand side here, on the x-axis is the number of weeks after a transplantation, and with red representing 1 virus, blue representing 2 viruses, and smaller is 3 and 4 viruses. So you can see here that most people have at least 1 virus, but a significant proportion also go on to have 2, 3, and 4 viruses, complicating the whole early period post-transplantation. And that the greater number of viruses, such as more than 4 viruses, resulted in having a significant mortality, so decreased survival overall compared to 1 or 2 reactivations. So this really improved our understanding of tackling not only CMV, but understanding that there are other viruses which can contribute to the CMV-related mortality and morbidity. So I did some work here locally at Peter Mac and Royal Melbourne Hospital to try and understand sort of this mortality. And whilst looking at the entire group overall, there was no decreased survival between whether you reactivated CMV or didn't reactivate CMV in over 400 transplant recipients. What I did clearly find was that if a patient was complicated with acute graft versus host disease within the first 100 days of transplantation, plus had CMV reactivation requiring treatment, that they had worse overall survival of 48% by the end of the study compared to 66%. So you can see on the right-hand side here that these survival curves clearly diverge with worse outcomes with CMV in a combination of acute graft versus host disease. The other matter I talked about was other opportunistic infections. So whilst CMV in itself, we better understand the morbidity and some of the mortality with it, but perhaps the CMV also increases the risk of other invasive, such as invasive fungal opportunistic disease, and that also contributes to morbidity and mortality. So this is potentially another indirect effect of CMV, and I, in the same cohort of studies, same cohort of allogeneic transplant recipients, I found a cumulative incidence of late onset invasive fungal disease, so in patients who had CMV reactivation versus those who did not. The mechanism of this is unclear, however. Some of the hypotheses around it, which I'm exploring in my current studies, was whether this was related to treatment, so neutropenia related to anti-CMV treatment. Was this a direct viral effect that then predisposes patients to invasive fungal infection, or was this a complicated immune-related interaction? So therefore, again, we can, any efforts to prevent or improve CMV infection may also subsequently improve outcomes with invasive fungal disease. So moving on to something more directly related to antimicrobials, I'll just run through some of the new and currently available CMV treatments to give you a bit of an update in this sort of specialised field. So when talking about CMV antimicrobials, it's important to just understand where it's being used. And so in the prevention side of things, whether an agent's being used as a universal prophylaxis, meaning that anyone at risk of getting CMV goes on to treatment. And in this sphere, we've not had any great treatments in this area for a very long time until more recently a drug called Letimavir, which I'll tell you a bit more about. And with universal prophylaxis, it's clear that we sort of do overtreat unnecessarily in some of these patients. So there's some good refinement that we can do. And we are also concerned with more universal approach to treatment may also be a risk factor for development of viral resistance if not taken correct, if the drugs are not taken correctly. In the preemptive monitoring phase of treatment, and by that I mean sort of re-stratifying those who develop CMV viral load will then go on to treatment. We have several options in this space. So ganciclovir, an oral drug, versus ganciclovir foscarnet, and a newer drug called maribavir. So Letimavir is a new anti-CMV drug, which has really found a place as a universal prophylaxis strategy. It binds to the CMV terminase complex rather than the polymerase, which ganciclovir does, and it interrupts a late stage of viral replication. And the beauty of this is that it's very specific to CMV viruses, and therefore it has much less minimal myelotoxicity, which has been one of the barriers to the standard treatments of valganciclovir. And it's available in IV and oral formulations. And the data supporting the use of Letimavir in the universal prophylaxis space comes from this randomized control study from Francisco Marti, published in the New England Journal of Medicine, which looked at universal Letimavir prophylaxis versus a placebo of a preemptive monitoring as per the local institution. So over 600 patients were enrolled in this study, with a primary endpoint being week 24. And you can see clearly here in the cumulative rate of CMV infection that the divergence between Letimavir and placebo occurs early, with most people receiving placebo having reactivation by week 14, and the inverse where Letimavir suppresses CMV infection in the first 14 weeks, and then you get a small blip of those who go on to have a reactivation after this. But this study clearly reached its primary endpoint and showed effectiveness. What was interesting about this study and somewhat unexpected was that it also, Letimavir in this setting also improved survival. So when they looked at death of all causes through to week 48, they found at week 24 there was improvement in outcomes, with only 10% of patients, patient mortality in the Letimavir group versus up to 16% in the placebo group. And this was statistically significant, but it wasn't out to week 48. But you can see from these survival graphs that the lines don't cross. So there's some good evidence to show that not only does it prevent CMV infection, but might also have a survival benefit. However, so this study has led on to Letimavir being pretty much standard of care throughout North America, Europe, and some countries in Asia, but not yet Australia. Maribavir is another new antimicrobial or anti-CMV agent, which is currently under investigation in the setting of preemptive treatment. And again, this is more unique in that it directly targets CMV, is good against ganciclovir resistant CMV, and has a much more tolerable side effect profile. That is, it doesn't affect the bone marrow as much as ganciclovir. Unfortunately, the phase 3 trial of its use in primary prophylaxis failed, and it's currently in phase 3 study as preemptive treatment. So watch out for this potential new treatment over the next coming years. So what do we have currently available in Australia? And that's ganciclovir, or its oral drug, valganciclovir. And this is nothing new. This has been around for 30 years. And so this is what we're using, but we still have to find better ways of using it. It's a first-line treatment for CMV, a nucleoside guanine analog, which inhibits the DNA polymerase, but however has significant toxicity issues limiting its widespread use. So therefore we can't use it in a primary prophylaxis setting. And even when we use it in treatment setting, neutropenia occurs in 42% of these patients. It does require renal adjustment, which, as you can imagine, in the transplant setting fluctuates on a week-to-week basis. And Karen Thursky published this pivotal study showing that ganciclovir use was associated with an increased hazards ratio of 13 for development of invasive aspergillosis. So this is a toxic drug. It's the only one we have, so we have to use it probably in a better way. Talking more about the toxicity of neutropenia, this French study showed that a large proportion do develop neutropenia, and the risk factors for this were that baseline neutropenia, which transplant recipients already have, renal impairment, and a high viral load. They also observed a significant 20% with invasive fungal infection in this group who did develop neutropenia, and 25% with concomitant bacterial infection. So whilst we treat the CMV, we have these other non-ideal side effects. So how can we do better? So one aspect which we're looking at in NCIC here through Sue-Ann Ho, one of our PhD students, is therapeutic drug monitoring. So currently valganciclovir therapeutic drug monitoring is not current standard of care, nor is it easily available. But there's a huge unmet clinical need in this space because there are the known dosing algorithms, even when they're adjusted for renal function and weight, are highly variable. And this is a very unique population who have poor gut absorption, fluctuating renal function. And when we did a literature review of TDM in the allogeneic transplant population, we found very few good studies. It was poorly evaluated. It's better done in the solid organ transplant recipients, but clearly we need to optimize what we have currently available and try and understand a bit more the interaction between the drug and toxicity. And we currently will have a study evaluating TDM in this group. The other treatments that I'll just mention briefly, foscarn and cidofovir, are equally very toxic to the kidneys, and they are limited by only being able to be delivered intravenously. So that leads me on to the healthcare cost and the burden of CMV. When we looked at a study, again, done at Royal Melbourne Peter Mac, found that the attributable cost of treating CMV is 52% higher than those patients who did not have CMV as a complication, equating to over 80,000 Australian dollars per patient. This led to more admissions, up to 12 admissions in this group compared to those who did not have CMV infection, and longer hospitalisation period. And some of this was due to the need to have intravenous ganciclovir, foscarn, or cidofovir inpatient. So I'll just move on. I've talked a lot about the viral aspects of improving CMV outcome. I've talked a lot about the drugs, but the other major component to getting on top of CMV, which hasn't been discussed, is immunity, and whether we can do better to understand immunity and prevent CMV poor outcomes. So one of my research focuses is looking at immune monitoring and trying to capture those patients who are at high risk versus low risk of further CMV complications. And whilst there's a lot of different methods which we can use to look at CMV immune monitoring, it's been shown in the literature that you can use it to guide the duration of your prophylaxis, to predict viremia, CMV disease, and even spontaneous clearance. And the question still arises whether we can use this tool to guide secondary prophylaxis of CMV disease. So in a previous study, I looked at a very simple assay called the quantiferin CMV assay, which can be done in routine laboratory setting without needing specialised laboratory equipment or resources. And I looked at CMV-specific T cell in a cohort of transplant recipients, and I used a variety of techniques, but the CMV quantiferin assay was by far the most simple. And I looked at 3 monthly intervals within the first 12 months. And I found that, that looking on the left-hand side at 3 months, patients who had a reactive or suggestion that they had developed CMV immunity, 50% of those were associated with spontaneous viral control and good outcome. In contrast, those who developed an indeterminate result on the quantiferin, all the patients who developed CMV disease were in this group of indeterminate responses. And on the right-hand side here, if I just point to the this red barrier here, if you developed CMV immunity showing a reactive response, overall you had a much lower peak CMV viral load. We can use this to monitor longitudinally over the first 12 months, and you can see that over time, the quantiferin CMV across all groups, whether you controlled your virus, had clinically significant reactivation or CMV in disease. You can use this tool to monitor that CMV-specific immunity improves over time. And lastly, just very briefly, how else can we harness the immune system to better improve outcomes? And one exciting development in this field is by using not only CMV-specific T cells and infusing them to treat the viral infection, but also multiviral cytotoxic T lymphocytes. So use of these T cells can be used to manage very difficult resistant refractory, not only CMV, but also EBV and adenovirus. And this is one of several studies published by the Westmead Group in New South Wales, showing that infusion of these cells over a long period gave an overall response of 93%, and also a partial response further down the track. So this is another sort of exciting area in the field where we can use the immune system to deliver direct anti-CMV therapy without using drugs per se. So to conclude, we're always learning new things about not only the virus, the drug and the immune system to try and improve overall CMV infection outcomes in this highly immunosuppressed group. We better understand now the impact of CMV and CMV viral load in this group. There are some new anti-CMV agents on the horizon, but I argue that we still have a long way to go on how best to optimise what we have currently and also what is coming out, and there'll be a shift towards universal prophylaxis. And lastly, an exciting area where we can use immune system to not only monitor, but also as a form of therapy against these difficult viral infections. And I thank you for your time.
Many thanks, Michelle. Certainly, you provided us with a wealth of information here and in a very digestible form. Quite taken by some of these new agents, but also we're very mindful of the risks and sometimes the challenges of even using the old drug, ganciclovir. I'll open to others for questions now, so please feel free to pop a question on the chat, and Michelle can look at this in a moment. But just while you're perhaps posting something, if I could just ask Michelle, just maybe a little bit out of the square here, but concerning ganciclovir, and maybe stepping just a bit further afield than the virology and the host immune response, Do you see any scope for a health services approach to contribute to prescribing, to administration of ganciclovir in ways and means that is appropriate? Or perhaps even electronic systems, things that would flag if something is not quite in accordance with how we might expect a treatment course to be progressing. Do you see any scope in this kind of novel space concerning particularly systems and support for prescribers?
Leon, that's a really great question, and I'm going to note that down.
That's fine. I wasn't meaning to take you off guard.
Yeah. Taking a step back and looking at improvements via systems, and definitely, I think we really should harness EMR and electronic systems which may alert you to development of neutropenia whilst on ganciclovir, or adjustments required due to renal function, which can change within days. And rather than the traditional passive response of just a clinician waiting to look up the results, that our new electronic systems can be a bit more proactive, and there is scope to develop a sort of an antiviral health systems approach across the precinct to better utilise all antivirals. So very much food for thought, taking the next step. Thanks, Leon.
Open for other questions here today. Okay, we've got a question here from Lynette. Hi, Michelle. Thanks for an excellent presentation. With the CMV reactivation association with invasive fungal infections, did you look at steroid use in this cohort? I wonder if it was a contributory factor.
Yes. So I did look at steroid use, but Lynette, as you know, the documentation of steroid is very difficult. And the literature does in fact show that steroid use is a risk factor for both invasive fungal infection as well as CMV. So this is observational only. I did have trouble collecting the data. I had about 75% of the data, and this was asked by the reviewers. So an important factor, no doubt contributing, but I couldn't completely evaluate it in this particular cohort.
Any other questions for Michelle? No? Okay, well, I think our time is almost up now. So I do, once again, thank you, Michelle, and we again virtually clap and give you thanks for your presentation today, and look forward to ongoing updates concerning the challenges of CMV. We'll move now to our third presenter for this afternoon, who is Anna Khanina. Anna is also affiliated with the National Centre for Infections in Cancer, but by trade, Anna is a pharmacist and has done a lot of work in the space of implementation and support for clinicians, for example, in the space of sepsis management. She's also now a PhD scholar with the NCIC. So I'll invite Anna now. She's going to speak to the topic of antifungal stewardship in Australia. So many thanks, Anna. Over to you.
Thank you very much, Leon. So I was having trouble finding the unmute button, but I think I've got it sorted now. Great. So thank you.
Hearing you loud and clear.
Okay, great. Thank you so much. So as Leon mentioned, my name's Anna. I'm a antimicrobial stewardship pharmacist and currently working in the area of antifungal stewardship. And I want to talk a little bit to you today, bit of an introduction, just to talk a little bit about setting the scene of why antifungal stewardship is important and have a look at its use in Australia at the moment. We'll review some of the literature around appropriateness of antifungal prescribing and look at some of the interventions that are available to optimise prescribing as well. And I'll talk a little bit about some of the work that we've done at the NCIC to help to implement antifungal stewardship. So just a bit of a background, invasive fungal infections. Just a bit of an introduction. I want to talk briefly about what invasive fungal infection is. So fungal infection is quite a broad term, and fungi are part of our normal flora on our mucosal and skin surfaces. Fungal pathogens are generally opportunistic. So we have colonization and we can get fungal overgrowth, which can lead to infection. This tends to occur in immunocompromised patients, or it can occur when there's a breach in our mucosal surface, such as a GI perforation or mucositis. So we firstly have superficial infections, which are infections that happen on the skin or on mucosal surfaces, and these tend to be less severe infections that can generally be treated with topical agents or non-absorbable agents, or also oral fluconazole or terbinafine. Then we have systemic infections, and these refer to more deep tissue infections or infections from a normally sterile site, such as blood, organs, or connective tissues. And these are more severe and they carry higher morbidity and mortality, and they usually mostly occur in patients with compromised immune systems, such as patients undergoing treatment for cancer, organ transplantation, patients that are in the ICU and are critically unwell, or patients that have a GI compromise, for example, surgery or mucositis or perforation, where fungi can translocate and enter otherwise sterile sites and cause infection. And then disseminated infection occurs when fungi spread to multiple organs or tissues, and together these cause are known as invasive fungal infection, and this really is the focus of what antifungal stewardship is about. So just really briefly, there are two main types of fungal infections caused by yeasts and by molds. In Candida is a prototypic yeast infection. Candida species, they form part of our natural mucosal microbiome, but through opportunistic infection, they can cause life-threatening disease. Candidemia is infection of the blood and is the most common type of Candida invasive fungal infection, and it can also spread to other sites such as to the heart valves, the liver, and to the spleen. A study of Candidemia in Australia was published in 2017, and they reviewed 12 months worth of Candidemia isolates from labs across Australia, and they found that just under half of all of our isolates were Candida albicans, and these have very low levels of resistance to fluconazole, just about 0.9%, which was really great. The study did find that there's an increasing incidence of non-albicans Candida, in particular Candida glabrata, which was about 26% of all isolates. And this is compared to a similar study that was done in Australia in 2004. And it found that over these 13 years, there was a 1.7-fold increase in the prevalence of glabrata. This is quite concerning because Candida glabrata has a higher rate of azole resistance, and often it does require treatment with broader spectrum antifungals such as echinocandins. And more recently, we've seen the emergence of new Candida species, in particular Candida auris, which is a multi-drug resistant yeast that was first isolated in Japan in 2009. Candida auris, it poses a public health concern because it is spread quite easily in the healthcare system. It can be quite difficult to isolate and identify in the lab, and it is resistant to all three main classes of antifungal agents, so definitely a concern. We have seen a little bit of it here in Australia. And the mortality from invasive Candida infection is quite high. It can be as high as 40%. Invasive mold infections, so Aspergillus is the most common type of mold infection. Infections tend to occur again in immunocompromised patients where spores from the environment can enter the respiratory tract and they can cause infection, typically in the lungs and in the sinuses. Again, we are seeing increasing resistance of antifungal agents to antifungal agents. In Australia, the rate is still quite low, less than 3%, but there is rising resistance internationally, particularly in the Netherlands, where in a short period of time, they saw a rise from 1.7% to 6% Aspergillus resistance to azoles. Resistance can occur from selective pressure of these pathogens through indiscriminate antifungal use, and also from widespread agricultural exposure to azole antifungals as well. And again, invasive mold infections do have a very, very high mortality rate. And there are also other non-Aspergillus mold infections such as Fusarium, Scedosporium, mucormycosis. Again, there are limited antifungal treatment options. These infections are very difficult to diagnose, difficult to treat, and have high mortality rates. So why do we care about fungal infection, and why is antifungal stewardship so important? So I've sort of touched on a bit of this already. We do know that we have a high burden of disease. Globally, there are 300 million life-threatening infections due to fungal infections that occur every year, and the mortality from these is very high. We have 1.6 million deaths that are occurring each year from invasive fungal infection globally. The cost for managing invasive fungal infections is quite high. There was an Australian study that was done that showed that the cost of treating one IFI in an Australian hospital is around $80,000 per patient, and this includes the cost of antifungal drugs, prolonged hospital admissions, ICU stays, investigations that need to be done as well. Patients that do develop an invasive fungal infection also it does present more complications, as it can affect the treatment of their underlying illness. So for a patient undergoing treatment for cancer with chemotherapy, if they develop a fungal infection, there is a chance that their chemotherapy may need to be delayed, delaying their treatment and therefore potentially increasing their chance of progression from their underlying illness as well. We are seeing increasing at-risk groups. So there are more patients that are being diagnosed with cancer, more patients that are living longer, and therefore more immunocompromised patients overall, and therefore increasing use of antifungals, not only for treatment, but also for prevention of infection. We are, as I mentioned earlier, seeing increasing resistance to azole antifungals amongst yeast and molds. There are limited treatment options. We have really three main classes of antifungal agents, and we're not seeing too much more coming on the horizon in the near future, unfortunately. And there are some limitations to the use of antifungals. They're hard drugs to use. They've got high levels of toxicity, lots of drug-drug interactions that we need to be cautious of. They have poor bioavailability and a lot of interpatient variability as well. So how does antimicrobial stewardship differ from antifungal stewardship? Well, they are very, very similar. So the goals of antifungal stewardship overlap. So we want to optimise antifungal use. We want to improve patient outcomes, of course. We want to reduce adverse sequelae. We want to ensure cost-effective therapy, and we want to conserve our antifungals. But there are some unique challenges for the use of antifungal agents, or for antifungal stewardship in particular, that are a bit different to that of AMS. Patients with invasive fungal infection, or patients who are at risk of invasive fungal infection, they tend to be quite complicated and often have many comorbidities. These patients are often undergoing treatment for hematological malignancy, oncology patients, transplant recipients. So we need to have a really good understanding of the risk factors for developing these infections and how they vary between different groups, especially as there are lots of new treatments emerging now. Managing these infections can have flow-on effects for managing their underlying illness and the level of immunosuppression that they can receive, therefore putting other treatments at risk, as I mentioned before. It can also be quite difficult to diagnose these infections, so having a really knowledgeable understanding of the microbiology that is available, what rapid tests are available, how to interpret them and how to apply them to your patients is really essential in antifungal stewardship. So it's quite a complex area that does require input from experts in the field. And then there are the other factors that we've touched on, which are the high mortality rate, high toxicity, high costs, and also should mention that it's really, really essential to build strong relationships with the primary teams that are managing these patients. Hematologists, ICU specialists, they are quite used to managing invasive fungal infections. They have the knowledge, they have the expertise. So to be able to work with them, to engage them, to be able to work on quality improvement with them, rather than really telling people what to do, I guess. So antifungal consumption in Australia. So I came across, as part of the INCAS Antimicrobial Awareness Week posters, I came across a poster from the NORSE team looking at antifungal consumption in Australia. And they have actually done some analysis of data over 3 years, from 2017 to 2020. And they found that in that period of time, there has been overall increase in the usage of antifungal agents across Australia, with the DDDs increasing from 33.5 in year 2018 to 35.3 now. And in particular, we've seen an increase in the use of liposomal amphotericin and also posaconazole. Just wanted to highlight that antifungal usage is really central in the haematology and oncology in the immunocompromised patients, where you can see here, these are the DDDs in this top area here in the brown. This is the usage in the haematology oncology units, much higher at 352 DDDs per 1,000 occupied bed days, compared to ICU, which is 130, and overall hospital was 35. So this really is the area to focus on when we are doing antifungal stewardship, followed by our critically ill patients in the ICU. And this here shows that there has been a decrease in the use of voriconazole, while usage rates for amphotericin, echinocandin, itraconazole and posaconazole have all increased. And in particular, there's been a really significant increase in the use of posaconazole, which is this green line here. So this poster is available to have a look at on the NCAS website, so I encourage you to go and have a look at that. So it is important to understand the quantity of antifungals being used, but also it's really important to assess the quality of antifungal prescribing. Before you can start implementing any antifungal stewardship interventions, the first step is really knowing what your practices are. What is the quality of prescribing in your hospital? This can help you to identify prescribing issues and therefore to shape your interventions and therefore to achieve your ultimate goals, which are to enhance the prevention of infections, to improve the management of these infections, to optimise patient outcomes, preserve our antifungal agents and minimise costs for our healthcare systems. So this is some data from the NAPS audit. So this is Australian data from 2013 to 2018, put together by one of the physicians at Peter Mac, Abby Douglas, and she looked at antifungal usage in the haematology oncology population compared to other non-cancer population for all of the NAPS data. And she found that there's a much higher rate of antifungal use in haematology oncology, as we expected. 20% of all prescriptions in the haemonc unit were for antifungals, much lower than in the non-cancer population, which was just 3%. And the majority of this was for medical prophylaxis, as expected. And very high rates of appropriateness in the haemonc setting, 93.2% was considered to be appropriate. And this could potentially be expected because in the haemonc setting, it tends to be quite protocolized and guideline driven, therefore there would be high rates of appropriateness. And the top indications, as expected, were medical prophylaxis, oral and dental, and also IFI, of course. So having a look, so what I did want to say was that this is from point prevalence audit surveys. So one of the limitations, or some of the limitations of point prevalence for assessing antifungal prescribing is that it may not give the most accurate picture. So you're looking at one particular day and you're assessing appropriateness on that particular day. And as we can see, the majority of that prescribing is occurring in prophylaxis. So you will miss a lot of patients that are undergoing empiric therapy and also directed therapy for invasive fungal infection, and this is where appropriateness may potentially vary. It is also a potential that some auditors who are doing the NAPS regularly don't have the in-depth knowledge around antifungal prescribing in specific areas like haematology and oncology and transplant. And therefore, more specialised auditors may have different assessments of appropriateness than general NAPS auditors potentially. So having a look at what studies have been published around antifungal prescribing appropriateness internationally, in particular in the haematology and oncology setting, I found 6 studies that did do this, and they did this in different ways. Some of these were retrospective observational studies and some were repeat point prevalence studies, and they used different definitions for what appropriateness meant. But overall, there was quite a variable rate of appropriateness from 29.4% to 56.5%, which is quite low. There was one outlier study, which is an Australian study of 95.7% appropriateness, but this study did exclude patients where there wasn't a defined guideline for management. So that obviously will skew the results because that's where appropriateness can vary, is where there isn't a clear guideline about how prescribing should be done. So these studies found a number of key areas for improvements. In particular, there was prolonged duration of empiric antifungal prescribing with an average of up to 34 days for empiric therapy, and finding that 50% of patients treated with empiric therapy don't actually have a confirmed diagnosis of infection following investigation. So this really should be an area of focus, is our empiric prescribing and trying to minimise the durations and come up with a diagnosis as quickly as possible so that we can de-escalate and stop these patients on their antifungals as early as we can. Studies also noted a prolonged duration of prophylactic therapy, either because of premature initiation prior to the onset of neutropenia or ongoing use beyond a defined period of risk, with up to 70% of posaconazole prescriptions in this one study of AML patients considered to be unnecessary, resulting in additional spending of about €15,000 over 3.5 years. The rate of inappropriateness due to drug-drug interactions was also quite high in one point prevalence study. Additional areas for improvement identified were inappropriate choice of agent, incorrect loading and maintenance dosage, and also poor utilisation of therapeutic drug monitoring. So definitely does outline that there is definitely room for improvement in antifungal prescribing. So do we have any guidelines available? So fairly recently, these guidelines were published in the Journal of Infectious Diseases, and these are the core recommendations for antifungal stewardship, a statement from the Mycosis Study Group Education and Research Consortium. And these are really great guidelines which outline how antifungal stewardship can be implemented. And there are some Australian and New Zealand guidelines that are currently being drafted and put together and will be coming out hopefully early next year. So keep an eye out for those as well. So who should be on the antifungal stewardship team? The first step really is to build your multidisciplinary team with the necessary expertise in managing these infections and implementing a program. The role of the team is really to support the decision-making process by bringing together the available knowledge and expertise for the management of these infections. So of course, infectious disease physicians are essential for this, as are clinical pharmacists. Clinical pharmacists really they have the knowledge of the pharmacokinetic behaviour of antifungal drugs, which is crucial to select the most appropriate drug and the right dose. They also can help to identify significant drug-drug interactions and also can help to appropriately interpret therapeutic drug monitoring. So pharmacists clearly have a really important role in this complex process by interpreting the results, advising on dose adaptation, and coordinating really the whole cycle of events. Microbiologists are also key. There are lots of novel and rapid diagnostics that are available for diagnosis of invasive fungal disease, some of which are still emerging. So having a microbiologist involved to help to interpret results and to guide which tests may need to be done is essential. And really, really important is having champions from the treating units. So getting haematologists or transplant physicians or intensivists involved in your stewardship program is essential. It's important to include them in the decision-making rather than directing them on what to do. That way you get more buy-in and they're more likely to participate, and you may have better outcomes that way. So what are the interventions that are available to us? So of course, antifungal guidelines are really important. We have the national consensus guidelines on antifungal prescribing that were last published in 2014, and there is a new update that will be coming out early next year. And these include management of mold and yeast infections, management of cryptococcal infections, infection prevention, and prophylaxis as well. But it is also important to adapt these guidelines to local practice and to involve senior clinicians in your institution in putting together these guidelines. Therefore, you'll have greater sense of ownership and therefore greater uptake into the daily practice. It's important to consider local epidemiology, to consider your local drug formulary, and also the availability of drugs and the costs within your institution. Key areas to provide guidelines include prophylaxis in high-risk groups, empiric treatment, which will account for the highest proportion of antifungal prescribing. But of course, guidelines can't address all complex and heavily pre-treated patients with multiple comorbidities or organ dysfunction. So they really are a guide, but an important starting point. Other interventions, so pre-prescription approval is something that is really commonly done and can be quite helpful. These restrictive interventions, they can be quite effective, but it's important to ensure that we still do maintain timely access to antifungal agents to prevent unintended harm from delayed initiation of these potentially life-saving therapies. Post-prescription review is something that is commonly done in AMS and is very valuable in antifungal stewardship as well. It can help to identify deficiencies in prescribing practice, help to educate prescribers on the spot, and it's a great opportunity to reinforce key messages. This should be done at key time points in management. So when therapy is initiated, when it's empiric therapy, is a patient actually at risk? Have they had the appropriate tests done to aid diagnosis? Then you want to come back and review them once we have the key diagnostic results. When therapy becomes directed, is there an opportunity to advise cessation? If there's no indication that they do have an IFI, can we narrow the spectrum? Can we optimize the dose? Can we ensure that TDM is being done? When can we switch to oral therapy as well? Fungal diagnostics and stewardship and therapy drug monitoring stewardship are also really essential, as is education. So I just wanted to bring up this study that was done in Europe. It was a survey done of 121 physicians from 4 countries in Europe. They had medical physicians, ICU and surgical, and they asked them 20 questions about fungal infection and prescribing of antifungal drugs. And there was quite, it did highlight quite high gaps in knowledge. So for example, this one question, which do you think is the percentage of fluconazole resistance in Canada strains isolated from blood cultures at your hospital? Overall, only 24% of respondents had that answered correctly. As you can see, for all questions, there were high rates of incorrect answers. Less than the ICU physicians tended to do better in most areas. So this highlights that there is a gap in knowledge and that education is important, but education alone is not necessarily sustainable, so it should be done in combination with other interventions. An ongoing audit and feedback loop is also really important in all quality improvement activities, particularly to the high prescribing units such as haematology, potentially ICU as well. And we need to really be linking that feedback with key actions and changes so that data is able to influence practice. So looking at antifungal stewardship uptake in Australia, so there was a survey done by Karen Abanchich and others around Australian hospitals. They asked a whole lot of AMS staff in public and private acute hospitals around what antifungal stewardship practices are in place. 83 hospitals responded. Most of these were public and major city hospitals. And they did find that most hospitals are looking at antifungal prescribing, particularly focusing on looking at the costs and the quantity of antifungals that are being used, with appropriateness being looked at by less than half of hospitals, which shows a key area for improvement. And really, it is important to know how much antifungals you're using, but if you don't know if it's appropriate, how can you then act on that? And the key interventions that were being used in these hospitals were pre-authorization, post-prescription review and feedback, education. Local guidelines were used in less than half of hospitals, and surveillance of fungal infection was used very infrequently as well. So again, areas for focus could be local guidelines and surveillance of infection. This survey did also highlight that only 85% of hospitals have access to galactomannan for diagnosis of invasive mold infections, but it's often done off-site and therefore it can delay the utility because of delayed responses. Same with voriconazole TDM, only half of hospitals had access to TDM, and only a small proportion of them had this on site. So that's definitely an area for focus overall to help to optimise antifungal stewardship. And the perceived barriers were lack of dedicated staff time, AFS not being prioritised institutionally, and also difficulty in accessing diagnostics and TDM, as I mentioned. So do these AFS programs work? Particularly in the haematology and oncology setting? There have been lots of studies quite recently that have been over maybe the last 10 years looking at various AFS interventions and looking at their impact on various outcomes. So I identified 4 studies, particularly in the cancer setting. They were all before-after studies with variable combination of interventions such as prescribing restriction, post-prescription review and education. And a wide variety of outcome metrics were evaluated across 2 domains of quality and consumption, but no studies actually reported on clinical patient-centered outcomes or infection management quality metrics. So looking at quality, 2 studies assessed the quality of antifungal prescribing and both found significant improvements post-intervention, including improvements in drug selection, dosing, reduction in drug-drug interactions, and also improved duration of prophylaxis in AML patients. One study found there was a significant decrease of about 40% in antifungal consumption between the pre and post-intervention periods. And one study that looked at having consistent CT scans follow up for these patients, that they were able to reduce the duration of prescribing significantly as well. They also found high rates of acceptance of AFS interventions, and they were able to improve prescriber knowledge. So which metrics have been used internationally? So I just wanted to, as I mentioned before, there have been sort of last 10 years that we're seeing much more AFS studies that are being published, but they're all using very, very variable metrics to measure their interventions in the domains of consumption. As you can see, these are just some examples of some metrics that are being used to measure consumption. Then we have quality of prescribing, again, very variable. And then patient outcomes, again, a great number of metrics. These variability metrics, it makes it difficult to compare between hospitals, to compare between countries, even to look within one hospital in different units if we're looking at really different metrics. So we really do need clear guidance on how to comprehensively assess the quantity and quality of antifungal stewardship to assist hospitals and programs to interpret data effectively and to structure suitable quality improvement programs. So what we did at the NCIC is we did a survey. The aim of this was to achieve international consensus on a core set of metrics to monitor the impact of antifungal stewardship. So we wanted to gain consensus on metrics around the areas of consumption, which is looking at the usage, drug expenditure, lab expenditure, the quality of prescribing and infection management, clinical outcomes and microbiological outcomes, but also to look at the feasibility. How easily can we routinely collect and report on this, and what are some of those barriers to implementation? So what we did was something called a Delphi study. A Delphi study is a qualitative research method to obtain reliable consensus of opinion in a group of experts. So what happens is you have a facilitator. The facilitator in this case was the steering committee of the project, and we did a literature review to find all of the metrics that have been used to measure antifungal stewardship interventions. We then compiled a group of experts. These are experts in the field of antifungal stewardship or invasive fungal infection management, or AMS, internationally. We then compiled a survey, and we had all of the list of metrics that we had identified, and we asked them how important they felt that these metrics were. So we asked them, they provide a response back to the facilitator. We analysed those results, we summarised those results, and we sent them back to the experts. So for example, we said, in the last survey, only 20% of people felt that DDDs was an important metric to measure antifungal consumption. Does that change your mind? So we asked them to rate that metric again for importance, comes back to us as a facilitator, and basically you keep going until you reach your predefined consensus, and then you develop your final report. The benefit of this Delphi technique is that it's an anonymous process. Participants, they don't know who's involved and they don't know who's answering. And this can help because in a group setting, there can be quite dominant voices, quite dominant opinions that can then influence the rest of the group. And therefore consensus tends to lead towards those dominant people. So by having that done anonymously through this survey format, you do have other people's opinions coming into it because we are providing feedback about what other people said, but it's not known who is providing that feedback, and there's no dominant voice in that group. So we had experts, as I mentioned, from adult pediatrics, microbiologists and pharmacists with expertise in various areas. We invited 134 people, of which 82 consented, and we had high rates of survey completion for surveys 1 to 3. We did our literature review, we identified 51 articles that were relevant, and we then stratified our metrics into the 3 key domains. Those metrics were then reviewed by our steering group, where we included, excluded, or we added the additional metrics, and then we put these through to our group for consideration. This is the outcome. These were the ones that the metrics that came up with high importance ratings and variable feasibility ratings as well. So overall, we had 38 metrics that were agreed to be important. 21 of them had moderate to high feasibility, which is quite great. A lot of these, actually, we found that a lot of the NAPS metrics that are already used can be applied in the antifungal stewardship setting as well. And these will help provide a framework to comprehensively assess the quantity and quality of antifungal prescribing. It will allow benchmarking within and between units, between hospitals and also countries. And if you're interested to have a closer look, this is published in the Journal of Antimicrobial Chemotherapy. So you can have a look to get the full results there. So with those results, we are now working with NCAS and with NCIC to develop the antifungal NAPS. So this will be within the hospital NAPS platform, but it's a deep dive audit, and it really helps us to assess each phase of antifungal prescribing. We can look at the prophylaxis in high-risk patients, we could look at empiric and also directed prescribing. We can direct the audit to look at a particular area of interest. For example, you may want to focus on a particular drug, You may be interested in all of your echinocandin prescribing. You may want to look at a particular indication or at a particular patient group. And the benefit of this is some similarities to the surgical NAPs, because we are also going to be collecting outcome information for patients and looking at, in particular, breakthrough infection rates in our haematology patients, and this can help to guide our institutional prophylaxis guidelines. So this is something that we're hoping to have ready hopefully mid next year, and we are very keen to have hospitals participate in that with us and to get involved in the pilot. So if you're interested, please get in contact with myself or with NCAS and we can get you involved as well. I just wanted to mention that we do have our NCSC symposium. So if you're interested in fungal infections and their management, that's happening on the January 30th, and registrations are now open. And it's together with Jason's antibiotic allergy and practice workshop as well. And that's all from me for now. Thank you.
Many thanks, Anna. A terrific emerging area, but in the sense, I like the way this is finding maturity, and particularly taken by the work you've shown us there towards the end, which you've been so involved in. I do understand. And to start to see some standardisation, some goalposts and some clear frameworks developing here is a really, really important and essential step. I'm sure that all would agree who are listening in today. I think we have one question that's been posted here, but I'll just pose one for you to think about before you answer that one. And that is, we know that antifungal stewardship, like other forms of stewardship, does come at some resource cost, if I say it that way. If we were to be thinking as hospital administrators or executives, and I'll just pop a hypothetical question to you here, do you think there's a major drive, or do you think it's a combination of drives that ought to be put forward to support antifungal stewardship activities? In other words, do you think it's costing considerations? Do you think it's reductions in toxicity? Do you think it's improved clinical outcomes? Do you get a sense that any one or combination of these is going to be the best way for teams and programs to be seeking resource and support as we move ahead?
It's a great question, Leon. I think everything that you mentioned, all of those factors are important, particularly to clinicians. The reducing toxicity, improving patient outcomes, reducing resistance are very, very important. But perhaps from a hospital executive standpoint, it's the cost savings that we could potentially also be using to I guess, to sell it to those people to get the funding. Because one of the bad but also good things about antifungal agents is that they are quite pricey, and so by being able to show that we can reduce costs, particularly if we're able to reduce echinocandin usage empirically, for example, and switch to fluconazole where appropriate, that can cause significant savings. So if we can show those savings to our hospital executives in conjunction with all of the other more clinical improvements, we can hopefully get more traction and support to get the resources and the funding to be able to do the work.
Okay, no, thank you. I appreciate your insights into this. I'm noting here the question or questions that have been posted here from one of our listeners today. I'll just read this one out for you, Anna. Is antifungal stewardship adjacent to antibiotic stewardship, or a separate program with a separate committee? Question.
I guess it depends on the individual hospital, but the way that I see it is that it would definitely be a part of antimicrobial stewardship. It wouldn't be something that is done entirely separately, but there may be some additional expertise that you may need to bring into your AMS team that have greater involvement and work with the haematology and transplant patients that you need to bring in and to be involved. As I mentioned, you need to have good buy-in, good relationship with those teams to be able to implement interventions. And I think certainly in hospitals that I've worked in, we tend to leave haematology and transplant to do their own thing because they often have ID physicians associated with them and they have their own processes in place. But having AMS involved and AFS combined, I think can be really, really beneficial. But I think you do need that expertise to work together because AMS on their own may not always have the expertise that you need at all hospitals potentially.
So merits for both an integrated approach or a targeted or a standalone approach, depending on the needs of the organisation or the patient population, I dare say, as to who's being managed.
Exactly.
One other very specific question here concerning antifungal therapy in adult ICUs and concerning the use of empiric antifungal therapy. Do you feel to answer that here, Anna? I'll read it out to you.
Sure.
One would be the more effective as empirical antifungal therapy in adult ICU? Azoles or echinocandins? Azoles show moderate to serious adverse drug reactions and drug interactions, and echinocandins are costly. And this has come from one of our listeners from Bangladesh this afternoon.
Leon, you're writing the new Canada empiric prescribing guidelines, so maybe that's something that you're better to answer. But I think that in Australia, certainly the guidelines that we currently have do support empiric echinocandin use in those settings. Knowing your hospital epidemiology is also really important, and knowing what your levels of azole resistance are and what your levels of non-albicans Canada are will help to guide what drug you choose. I think it's difficult to say broadly. I think it needs to be institutional. Leon, would you have anything?
Yeah, look, I do agree, and that would be my one statement here. And there's also, I think, just been some recent guidelines put out by the ECMID group concerning ICU empiric and prophylactic and preemptive strategies. In fact, the guideline itself doesn't strongly support this as an approach. So I think that's worth keeping in mind as well. So I'll just point you in that direction, and maybe we'll just steer away specifically from teasing apart these two particular agents, because once again, there will be some local epidemiology that comes into play here, particularly in parts where there's high prevalence of gram-negatives and other infections. Well, I think we're pretty much out of time for this session, Anna. So again, on behalf of our listeners here today, just to give you a big thanks and certainly acknowledge that you've provided a considerable amount of work here and given us a beautiful picture of the current landscape, as well as the substantive work that you've made already in this space towards standardised metrics for antifungal stewardship. So thank you once again.
Thanks, everyone.
Now, I'll just take the opportunity now to introduce our fourth presenter for this block, who is Belinda Lambros. Belinda is also affiliated with the National Centre for Infections in Cancer. And she, unlike our other speakers today, Belinda is a nurse practitioner. She has a high level of experience, having been involved at levels of ICU as well as cancer care in previous roles. And she's coming now to the end, or I should say, is going through the endorsement process for her nurse practitioner candidature. This has been an important focus for the NCIC to ensure appropriate models, appropriate capacities are supported through research activities. So I introduce Belinda this afternoon, who's going to speak on the role of the antimicrobial stewardship nurse practitioner. Thanks, Belinda.
Thanks, Leon. Can everyone see my screen?
Not yet.
Okay, bear with me 2 seconds.
Terrific. Yes.
Are we right now?
Yes.
Great. Thanks very much. Thanks for the kind introduction, Leon, and thank you to NCIC and NCAS for allowing me the opportunity to have a chat about nurse practitioner role in antimicrobial stewardship. I guess, yeah, as Leon said, the APRA at the very end stage and waiting for endorsement with them. They are holding my paperwork hostage at the moment, but we are hoping to have a chat about what the role will be in advanced nursing practice in antimicrobial stewardship. So the aim for today is to discuss the background of AMS and antimicrobial prescribing in the immunocompromised host, specifically in reference to cancer patients, and then linked to nursing roles and responsibilities. I will then describe some of the key components of antimicrobial stewardship service and how nursing and advanced nursing practice roles can optimise these programs. And obviously I am preaching to the choir here when I talk about the goals of antimicrobial stewardship programs in this forum. So I'm just going to highlight a few of them in order to set the scene to facilitate how advanced nursing practice can be linked to it. We all know the saying that knowledge is power, and therefore educating healthcare workers and providing them with up-to-date information and evidence-based practice will facilitate adherence to guidelines, which in turn reduces the inappropriate antimicrobial use and also decreases potential medication errors or adverse events. Less adverse events means better prescribing and will reduce healthcare costs and limit antimicrobial resistant infections. And everybody wants less C. diff in the world, especially all of us nurses. All of these things do impact our halo, which is why we got into healthcare in the first place, which is to improve patient outcomes. So in cancer patients, cancer affects all of us in one way or another. The risk of cancer is significant in today's society, with over 1 million Aussies either living with cancer or have had to learn what it means to be a cancer survivor. Almost 400 are diagnosed, and sadly an average of about 136 people do lose their lives to cancer every day. And the biggest complication of cancer treatment is infection. The burden of the hospital system is also thought-provoking in that 1 in 10 hospital admissions are cancer-related, and over half of them are related to infection. From the NAPS survey and data, we know that 70% of all cancer patients will have a prescription for antimicrobials at any one time. And we know that in hematological malignancies, 80% of patients will have an episode of neutropenic fever. In medical oncology, the infection rate is about 50%. And in radiation therapy patients, approximately 13% of them will require admission, but once they're admitted, the risk of infection is about 50%. There can also be the difficulty differentiating between radiation skin side effects, such as breakdown, and infection to those areas. And the risk of infection in surgical patients is between 30 to 50%, depending on the complexity of the surgery. And there's also the surgical prophylaxis work that we also love to discuss with the treating teams. We also know from the NAPS data that approximately 1 in 5 patients receive inappropriate therapy based on prescribing habits from the Australian Survey of Australian Hospitals. So there's this big balancing act. There's a fine between AMS practitioners, and that's what the work is that we need to do. We must weigh up the risk factors of the immunocompromised patients that have such as the risk factors that they have, such as patient-related factors, disease-related factors, treatment-related factors, and of course the clinician's prescribing habits and the concerning problems of AMR and C. diff. So when you go back to my first slide, you'll see the goals of AMS programs, and you look at the nursing roles at each and responsibilities that are outlined in the nursing standards of practice. There's clear synchronicity between these goals and the standards. Even though this slide is a little busy, I hope it allows me to illustrate how nursing is intertwined with AMS. Nursing Standard 1 is the expectation that a nurse thinks critically and analyses nursing practice, and this covers the AMS goals of compliance with guidelines when making decisions for patient care to ensure safe and quality practice. Nursing Standard 2 is the expectation that the nurse will engage in therapeutic and professional relationships and provides support and directs people to resources to optimise their health-related decisions, which covers the AMS goal of improving patient outcomes. Nursing Standard 3 ensures that staff maintain capability for practice and accept accountability for decisions, actions, behaviours and responsibilities inherent in their role, which as bedside nurses, adhering to guidelines and education is at its core. Nursing Standard 4 requires nurses to comprehensively conduct assessments and work in partnership with factors that affect or potentially affect the health and well-being of people, assessing resources available to inform planning and the well-being of patients. And this obviously ties in with the AMS goals of reducing healthcare costs. Nursing Standard 5 develops a plan for nursing practice, which ensures staff coordinate resources effectively and efficiently, which again ties in with the healthcare reducing costs. Nursing Standard 6 provides safe and appropriate and responsive quality nursing practice, which covers identifying and reporting potential and actual risk for the patient or the healthcare system, and links with the AMS goals of decreasing adverse events and limiting C. diff and multi-resistant infections. And Nursing Standard 7 encompasses evaluating outcomes to inform the nursing practice, which really encompasses all of the AMS goals into one. And the nurse practitioner standards can also be mapped quite closely with the AMS clinical care standard, with education, research and leadership being the backbones underpinning practice. These MP standards go beyond the registered nursing ones to provide a framework which includes assessing and using diagnostic capability, which provides guidance around diagnostics, including microbiological testing to inform practice. And this links in with AMS standards 1 and 2. Plans care and engages others, which covers the AMS standards 3 and 5 wholeheartedly. Prescribes and implements therapeutic interventions, which encompasses the AMS standards 4 and 6, and monitors outcomes to evaluate and improve practice, which provides synergy with the AMS standards 7 and 8. So the recommendations from the Australian Commission on Safety and Quality in Healthcare suggest that at a minimum AMS team should include representatives from pharmacy, infectious diseases, microbiology, and have executive involvement, as well as a link to an AMS network. I was quite surprised when I found this, and although I concede many infection control experts are nurses, they're not at the patient bedside, and there was only about 1 out of 6 of the organisations listed that had a nursing represented separately and as a recommended member of the AMS team. Nurses are half the healthcare workforce. We're the patient's advocate and translator at the patient's side throughout the healthcare journey. We work side by side with all members of the multidisciplinary team. Some of the activities nurses complete include AMS, completing the allergy assessment as well as physical assessments, initiating acute deterioration pathways and transmission-based precautions for patients, collecting the specimens required for the microbiology diagnostic tests, administration of the antimicrobials and medication management, patient and family education, completion of procedures such as cannulations and wound care, assessment, documentation and facilitation of patient suitability for admission, discharge or transfer to healthcare settings. So hopefully I've pleaded my case as to why nurses and nurse practitioners' roles in AMS are needed, and I'll now go into the core domains of my nurse practitioner candidacy at Peter Mac, which include early recognition of infection and sepsis, early step down through IV to oral switch programs, the low risk febrile neutropenia pathway, enforcing the approval systems to allow AMSTs to provide guidance on appropriate prescribing, antibiotic allergy assessment, vaccination programs in the immunocompromised host, and championing infection prevention programs. As nurses, we're the conductors of patient care and the first point of contact for many patients in many situations, and also for the healthcare professionals alike. Provision of education and support to the care team at the bedside ensure that AMS activities are understood and championed. Day-to-day monitoring of sepsis pathway, restricted antimicrobials, and opportunistically supporting patients with interventions such as vaccination, low-risk ambulatory care pathways, and antibiotic allergies is vital in efforts to optimise patient care of the immunocompromised host. Sepsis Going through sepsis. So sepsis is a medical emergency that, if not recognised quickly, the patient's condition can deteriorate into a critical situation within hours. Nursing practice. For the standard bedside nurse, assessing patients and completing those vital signs, identifying the risk factors, signs and symptoms of infection, notifying the medical team and advocating for appropriate interventions. And the advanced nursing practice role, looking at the education of the nursing and the multidisciplinary team about sepsis and deterioration pathways, completing post-criteria review to optimise care, audit compliance and informing bedside healthcare professionals of the results of those audits, and developing quality improvement initiatives to improve compliance and patient outcomes. Here are some quotes from nurses from the statewide Think Sepsis Act Fast rollout, which provided 24 hospitals with the Sepsis Pathway Care Bundle, which was initially piloted at Peter Mac under the great leadership of Prof. Key points to highlight, I think, include providing nurses with education and tools to empower them to feel confident to commence treatment for those critically unwell patients is very rewarding for the bedside nurse. So now moving on to the next area, the purpose of IV to oral switch program is to provide the multidisciplinary team with the objective criteria to determine appropriateness of antibiotic therapy and facilitate timely switch to oral medications. The rationale that IV to oral switch programs improve patient comfort, mobility and care, and reduce IV cannulation requirements and related complications, reduces cost and patient stay times, and finally assists in the prevention of antimicrobial resistance. So for standard nursing practice, they're the ones who know if the patients are absorbing, are they tolerating their other oral medications, or are they going straight through? Are they still having those febrile episodes? Are they vitally stable? Do they have any microbiology results that have come back to guide therapy, or do they have a complex infection? And they are great advocates to refer to ID. In the advanced nursing practice role, we're looking at the education of nursing staff on the antimicrobial stewardship programs, post-prescription review and recommendations to the treating team, audit and feedback of compliance with policies, procedures and guidelines. So if a patient has been deemed suitable for an IV to oral switch, then the next logical step is, can they safely be cared for in their home environment? This brings us to the next key area, which is the low-risk febrile neutropenia pathway. Mortality rates have improved over the last 50 years, increased from 30 to 40% down to 5 to 10% for patients having an episode of neutropenic fever. There's obvious high-risk patients who require hospitalisation, but there's also many patients who meet criteria for low risk of complications of this neutropenic fever and will be well suited to be monitored and cared for safely at home. The risk stratification used is the MASK tool and considers patient, treatment and expected recovery factors. Patients, when they feel well but stuck in hospital due to their counts, are really keen to go home, and they're often the best judge of whether they do feel safe to go home. In nursing practice, they can complete the patient assessment and vital signs. They can complete the MASK score risk tool. Is the patient suitable for IV to oral switch? Is the patient feeling well and keen to go home? Is the patient well educated on infection prevention strategies? And then the advanced nursing practice role, there's completion of comprehensive patient assessment, ensuring that the suitability criteria for the program is met, coordination of the anti-ambulatory care program, interpretation and follow-up of the diagnostic test results, telehealth and face-to-face follow-up with the patient. I've got two favourite stories of patients who've been on the program. The first one was a gorgeous 47-year-old events manager with breast cancer who was doing her squat lunges down the corridor while she was waiting for me to get things organised. There was no way she was going to stay in hospital for another night. And the other one was a lovely young mother of two who lived in Ballarat, but her partner and daughter were staying very close in some local apartments. So we were able to get her out on the program so she could put her 2-year-old daughter to bed that night. And the next day she count recovered, fortunately, which was the day before her 30th birthday. So then she was able to go home to Ballarat to celebrate with family and friends. So it's a very rewarding program, and the low risk toolkit is on the NCIC website. And the next component is antibiotic allergies. What is our role as nurses? So as Jason mentioned in his talk, 1 in 4 cancer patients will have an antibiotic allergy listed that leads to adverse outcomes for patients and inappropriate prescribing, drug errors, and increased length of stay. Penicillin allergy is not forever, and we know that 50% of people lose their allergy after about 5 years, and many are those historical childhood reactions. Nursing assessment is vital for these allergies, as we are the ones that put the red label on the patients, and we're the ones who ask the patients every single day, what are you allergic to? So it's very wise to also add a couple of other questions, knowing about what their reaction is, into that allergy assessment. And so having the nurses at the bedside completing those on admission does bode well for the patient, and it allows them to be referred appropriately to the antibiotic allergy program. So the basic nursing practice for those patients, for the nurses at the bedside, is that comprehensive allergy assessment tool that Jason showed. Monitoring for symptoms and signs of allergic reactions to any new antibiotics that the patients may not have had before, and monitoring antibiotic allergy challenges and notifying of any changes in patient condition. And the advanced nursing practice role that has been developed is obviously completing antibiotic allergy assessments as well, education for the multidisciplinary team on antibiotic allergy assessment and referral pathways, assessing appropriateness for the antibiotic allergy testing, discussion with the treating team and coordination of the testing, overseeing inpatient challenges, direct delabeling appropriately for those patients with side effects, and completion of skin prick testing procedures as well. The coordination of the antibiotic allergy program requires timely intervention and capturing appropriate patients when it fits in with their cancer treatment, preferably during the workup, before they actually start their treatment, so that they can have a clear antibiotic allergy label, or preferably not one, for when they come in for their treatment. And as Jason highlighted earlier, the vast majority have been direct delabeled or delabeled post-challenge, and so therefore this provides these patients with the best possible alternatives should an infection occur. And the next area is the vaccination programs. Patients who are immunocompromised require protection from vaccine preventable diseases at some point in their journey. High-risk patients to target for these programs include patients undergoing bone marrow transplants, CAR T-cell therapy patients, splenectomy or hypo or asplenic patients. And nursing interventions at the bedside include the administration of those vaccinations and patient education on side effects of vaccinations and infection prevention strategies. AMS advanced nursing roles in vaccination should include nurse immunisers, but additional specialist training and supervision is required for the immunocompromised patient group. Some of the factors to consider for these patients include omission of live vaccines post-transplant for about 2 years, additional boosters of the seasonal influenza vaccination may be required, treatment-specific risk factors such as bleeding or bruising risk to be considered, and whether delaying vaccination, depending on the patient condition due to risks, is an appropriate thing to consider. So in short, to the AMS teams, empower those who are at the patient's bedside throughout their healthcare journey, and to the nurses, you do more than you think you do, so take opportunities to be involved in AMS and join the choir. I'd love to know if there are any nurses in the chat session. Maybe just say hello, and it'd be great to get a bit of a bigger choir around. And I'd just like to acknowledge my supervisors and mentors at Peter MacCallum and with NCIC. It has been a very rewarding journey, and I'm extremely grateful to be working with the innovative clinicians that I do. I essentially see my work as spreading their amazing things to the bedside so that patients can get the benefits of the amazing work that is done. Thanks.
Well, many thanks, Belinda, and congratulations also in terms of your journey and what you bring to this particular role that you carry. An exemplar, I think, as a model for practice, and one that I'm sure many others can glean from here today. I too would be interested if there are any in the audience today who are of nursing background. I'm not seeing anything on the chat so far, but please make contact if I could encourage you to with Belinda. I'm sure she would love to continue that conversation and support and even provide sort of intel concerning how this type of a role and a model can be applied. We don't have a lot of time here, so I'm just seeing if there's anything coming through yet, but I might just ask a question, perhaps just more as a close off here, Belinda, but advanced nursing roles in the AMS space. You've had a lot of experience really in this area. As nurses that are skilled in particular fields, maybe potentially particular subsets of skills and capacities, do you see any groups or any areas of nursing that would particularly lend themselves to this role, or would you be advocating to say that all from far and wide could or could embrace this type of a model? What would be your thoughts on skill sets and capacities for practitioner roles to be developed into the future? That's my first question. And the second is just a general comment as to what you would see in terms of the potential for support for translational research.
So as I tried to highlight on that very busy slide, was that I think that every single nurse does AMS work every single day, and it's just harnessing that. And I think that, anyone who is interested in taking up the baton from nursing perspective should very much be encouraged, because it really is part of our everyday work, and it's just knowing that, I think, and providing them with the tools to be able to do that. And then, sorry, what was the second component?
What you see as the potential in terms of growth and development in the research space, perhaps at a translational research level. Do you see some big ticket items? You've raised so many today already, but what would you message in terms of that?
I think it is that audit and feedback. Obviously, we've done some work on blood cultures, and just providing that feedback is enough to decrease contamination rates, and that was part of our sepsis pathway work. Obviously, getting the nurses to do the antibiotic allergy assessments, and there's been work that's published there with Jason and the team. But I think that there's a lot of research there. And the one gap that I'm hoping to get to is really that patient experience.
Absolutely. Yeah, that's what I was wondering myself, but I think it's great to hear that from you. Patient experience.
Yeah, I think that it's so
really
vital.
Yeah, it is. Yeah. It is. Well, thank you once again for your insights and your presentation here today. And in fact, thank you to all of our speakers, to Jason, to Michelle, to Anna and Belinda here this afternoon. We are indebted to you for not just your insights, but also leading us forwards in terms of next steps, challenges, and perhaps the novel aspects here to stewardship activities for immunocompromised patient populations. So I'll close off the session now, and thank you all for your time and attendance today.
Thank you, everyone. Thanks.